I'm very pleased that we have Jennifer Wenzel here today to talk to us about disparities in recruiting people into clinical trials. As usual, I had never met Jennifer at Hopkins. I met her in Virginia at the Society for Clinical Trials meeting, and realized that we were kind of working on clinical trials, and we and our group were organizing a workshop, and I thought she would be a great speaker here, and also so we know what's going on in our own university. Jennifer has come from a nursing background. She's a nurse. She studied in the Southern Adventist University in Tennessee, and then she worked for a while doing nursing and clinical research, and then returned to school to get a master's at the University of Maryland, and then a doctorate in nursing at the University of Virginia in Charlottesville. She's been recognized as a young investigator with some early career awards from the Robert Wood Johnson Foundation as well as the American Cancer Society. And she's working on interdisciplinary teams here at JHU, where she's an associate professor with an appointment in the School of Nursing as well as the School of Medicine and at the hospital, to improve collaboration with cancer decision making and treatment for patients and care partners. And today she's going to be talking to us about a multi-center project for enhancing minority participation in clinical trials, which she is the lead investigator here at Hopkins. And so I welcome Jennifer and thank her for giving our first seminar of the year.
Thank you. All right, I think, let me know if I'm not projecting well. Is that a little better? Okay, all right. My husband says I have fairly loud voice, so, but I'm being amplified too, so. All right, well, it really is a pleasure to be here with you this morning. Thank you for coming out first thing in the morning. I am not a morning person, so I understand how difficult that can be at times. It's nice to see a few familiar faces in the audience as well. I really want to thank Janet and the rest of the Clinical Trials Seminar group, first of all, just for having a group like this where we can talk about important issues related to clinical trials, and also for inviting me to talk about our Enhancing Minority Participation in Clinical Trials Consortium. This is a group that's been together for a while. We've been working together across the country since 2009, so longer than, much longer than the typical Hollywood marriage. We start on the West Coast at UC Davis with Moon Chen, whose group has worked quite a bit with Asian Americans and recruitment and retention to clinical trials. We head south to MD Anderson with Elise Cook and her group. We are actually coordinated at the University of Alabama at Birmingham with Drs. Fuad, Vickers, and Durant. And here at Hopkins, following in the leadership of John Ford and Rich Zellers, who have previously helped lead EMpaCT here, I lead our group. And then at the University of Minnesota, we have Badrinath Kanedi. So we have had, I think, remarkable retention of our investigators in EMpaCT. This is a good group of people who are really committed. As I said, there's been no turnover in terms of the sites. All of the sites have remained consistent since we started. A little bit of turnover in terms of the lead investigators, but honestly that's either because folks like Lovell Jones at MD Anderson retired, or Jazz Alawalia and John Ford left. So essentially to leave our group, you have to leave your institution is sort of what it looks like. Why do we need a consortium? Well, first of all, we've had the NIH policy for inclusion for clinical trials since 93. Just to put that in a little bit of context, what were we doing in 93? Well, we had the other Clinton in the White House at that time, if you can remember that. We were watching Jurassic Park, the first Jurassic Park, in the theater, Sleepless in Seattle. We had Schindler's List. It was actually not a bad year for film. The Dallas Cowboys were actually still winning Super Bowls. I have to say that. My family's from Texas. But we haven't made a lot of progress when it comes to minority accrual, and we'll be talking about that today. The numbers don't look all that great still, in spite of a lot of effort and in spite of some national initiatives and some federal mandates. We're not working well individually, perhaps, so coming together as a group and thinking as a group, we thought might put us further forward. Really, if we were making as little progress in technology as we are in accrual of minority groups to clinical trials, we'd sort of barely still be working with microprocessors, and we'd just be getting introduced to the World Wide Web, again, to put all this in context. So we have a ways to go. Clicking. Sorry. Apparently, I move around a lot. So why do we care? I think that's important. You're all here. I find that encouraging to some level. That means that you care, or you need to be here for some other reason. First of all, it's good science to care about this issue and why and how we can get minority groups into clinical trials. We care about generalizability. It's something that we see in every research report, right? It's the first critique that we can provide of our research. We want to make sure that we're generalizable in our study findings, and especially to groups that we know have been underrepresented. It's important because we actually can use this information to generate new hypotheses. We really want to be able to have a sample that's sufficient to examine differences, particularly for my group of investigators related to cancer prevention, to diagnosis and treatment. And we want to do this because it's the right thing to do ethically. We want to make sure that the risks and the benefits of trials are being shared equally across groups. And we want to make sure that everyone has the same access to the information that trials really moves forward for us. So when we first got together, we thought, as groups do, we should get to know each other. And because we're a group of researchers, we decided to use data to do that. So across the sites, we did a qualitative needs assessment, and we actually did some qualitative work. Quantitatively, we looked at minority recruitment trends across the 5 institutions, and what we found was that even for our 5 NCI comprehensive cancer centers, there was a lot of variability in terms of how these types of data are reported. It was actually very challenging to pull this together, even across the 5 sites, which sort of tells us where things are probably at a national level. Qualitatively, we spent some time developing, with some stakeholder input, a series of interviews. And we did this with cancer center directors across the 5 sites, with referring clinicians, and also, I'm trying to step off this podium, also with research teams, so PIs and research staff, the people who are really on the ground recruiting people into clinical trials. We wanted to know, what are the actual recruitment needs perceived by these stakeholders? What are some of the barriers? What are some of the facilitators, very common areas of focus, and some best practices? From these 2 levels of information, we really worked on creating some actionable items. So we wanted to create, our original goal was to create a menu of options. Again, we're really looking at what can we do as a consortium of 5 cancer centers to really optimize minority recruitment and retention to clinical trials. And also, how can we make sure that this information gets disseminated out past our individual centers? The 2 areas that we decided to focus on based on our needs assessment were patient navigation, and I'll talk a little bit about that, and also the development of a web portal, which I'll also tell you about. So that's really been the focus of our intervention work. I think the system wants me to stay in place. So we designed the web portal to include some training that was identified as a need in the needs assessment. Investigators were saying, you know, we really haven't had very good training. People tell us this is important, but we don't necessarily know the best way to recruit minorities into clinical trials. We developed our modules across the 5 sites based on our stakeholder input. And we also included some of our patient navigators in this process. We wanted to make sure that the web portal could provide some resources for recruitment and retention. And really, it was designed to serve as a communication and information hub. So I have here just a screenshot of the website. This is accessible to the public. It's something that we used your federal dollars for, so we'd really love for you to use it, to get on there and access it. Some ways that the web portal is being used at the University of Minnesota, the CTSI has approached us about using the information on the web portal for their clinical research coordinators orientation. This would be to provide training and career development to the clinical research coordinators there. They have started incorporating the web portal into their training program. Again, this is nice, it's accessible for folks, and it is really available to anyone who can access the internet. And there is this potential model of enhancing use internally across the 5 sites. But again, it is accessible to anyone. So the modules that we have, Danny, yeah.
Well, maybe you can tell us this, but is it focused on people who are thinking or enrolling people in oncology trials, or is it have a more general focus?
So we really designed it, I'm sorry, I'm going to try to move this a bit. I think it's ideally placed for my voice, but maybe not for other things. Yeah. Thank you. Well, they tell you at Robert Wood Johnson in our media training, don't wear chunky jewelry when you're being interviewed, but not necessarily when you're... They didn't tell us about the speaking part. I think that's better. All right. Maybe it was my Hopkins ID. All right. So we have focused really on cancer clinical trials. That's the emphasis of our group. But I'll tell you, most of what we hear is that this information is pretty generalizable. And I think a lot of the information, even the information that has been developed for cancer clinical trials, probably has some wider generalizability, because actually accrual to clinical trials doesn't look much better than general clinical trial accrual in many ways. So what do we cover here? In case, just to sort of whet your appetite, we have modules on successful models for minority recruitment. We have a module on how to increase awareness of opportunities for trial participation. This really talks at the community level, starting there and then branching out. Assessing the effectiveness of our efforts is the topic for one module. And there's a really nice module on cultural competency that's been really well reviewed. So that's some of what we have on the web portal. Again, we are working on that. The web, you know, the nice thing about the web is it's, once you develop something, it doesn't have to be static. So that's sort of, this is a work in progress, but this is where we started. And there is some discussion about whether we could, we should look at being able to provide CEUs or some CMEs for these modules and completion. Questions about the web portal? Yes. It's hot up here.
Kinds of minorities is this focused on all, or are you focusing on some race?
Yes, I'm sorry. And I think when I was talking about the consortium originally, I started with Moon, because you always have to start with Moon. He's very charismatic. But each site actually focuses on a different group, and so collectively we do have a pretty wide inclusion. At MD Anderson, they're really focused on Hispanic and Latino populations for pretty clear reasons. Minnesota is focused on actually a more Arab American population, so quite diverse there. Also some African Americans. They're really a melting pot up there, but that's an area of specialization for them. Here at Hopkins, our primary target in terms of minority accrual has been African Americans. That's the largest minority group that we see here. And then at the University of Alabama at Birmingham, again, they're sort of the main center for African American accrual and also rural populations. Did that answer your question?
Yes.
Okay.
So the focus is on racial.
We really are focusing on racial and ethnic minorities, yes. Mm-hmm. But again, you know, because as I mentioned, we really don't, that is the majority of our focus, but we don't overlook issues like rurality, in part because of where some of our centers are located. Yes?
In this web portal, in kind of different languages or just in English?
So it is in English. However, there is accessibility to some of the information that has been developed in other languages, primarily Spanish, at MD Anderson, and there's been translation of recruitment and retention materials into Chinese and Hmong, actually, at UC Davis. So while we don't have all of that posted, there are definitely some links to that information, and again, the ability to contact those investigators because we have that information there. And those are the folks working on the ground who developed those modules. Other questions about the web portal? Great. So again, please get on, take a look at it, and give us feedback about things that you'd like to see there. That's really what it's developed for. So we'll talk about patient navigation. This has been a major effort for the consortium. Some of the things that we're trying to accomplish in patient navigation, this is something that's been going on at the University of Alabama at Birmingham for a while, so they have a really nice cohort of trained navigators who really become super trainers for the rest of the navigators across EMpaCT. We're really using patient navigators. These are lay workers from the community, lay healthcare providers. They provide clinic-based information about trials, and we'll talk a little bit about the specificity for Hopkins when I talk about some of our data here. They're there to support minority patients as they're enrolled into clinical trials. Again, we're interested in enrolling patients and also retaining them to studies. I think that's important because a lot of the literature is really heavily focused on recruitment. As though, you know, once we get people in, that's really the only battle, and it's not. There's a pretty high dropout as well in terms of clinical trials. Navigators really help patients overcome some of the logistical barriers that we know from the literature that exist, making sure that they're tapped into the resources that exist within the cancer centers. Again, these are all NCI comprehensive cancer centers, so there are resources available for patients. And also connecting with the community. Again, because our navigators come from the community, they are well suited to making sure that they're aware of what's out there for patients to assist them during their trial decision making and while they're in the trial. Our patient navigators are a really terrific group of folks, and we've actually had, again, because these are folks who are very engaged in the community, very invested in making sure that these resources are accessible to minority populations. They've actually helped identify where there no current resources exist in the community and helped to create those where they did not exist. They really are very aware of some of the cultural considerations and provide important emotional support for these individuals who are, again, enrolled to clinical trials. Yes?
Are they involved in the consent process, the patient navigators, for consenting participants?
Yes, yes. I think primarily we have them, so for example, in the trial that will be starting here, that's at the IRB right now, the patient navigators are going through all of our human subjects training, and they will be the ones obtaining consent. Mm-hmm.
So,
yes.
I know you're talking about cancer centers, but when we
So we're using cancer as a model right now. So right now, our funding is to have patient navigators for cancer clinical trials. But I can tell you, for example, when I've talked to the Johns Hopkins Clinical Research Network, and particularly when I've presented the model that I'll be talking later about this morning, you know, the investigators really raise their hand and say, we don't think this is just African Americans. We don't just think this is cancer clinical trials. We think this is applicable to all trials. But we're researchers. We don't like to generalize outside of the data that we have, right?
Yeah, because years ago in 1993, we did focus groups with patients and doctors, and they tended to think of clinical trials as cancer and AIDS and sort of end-of-life type things, not increase your exercise, you know, or something like that. And so there may be different attitudes when people see it as a life and death situation, whether versus change my behavior to try to, I don't know what.
So I'm going to actually present some data on more recent focus groups with cancer survivors, and I'll be interested in your input in terms of what the differences are from what you perceive. It does seem like the ante is sort of raised a bit when we talk about cancer, but I think it doesn't really explain our abysmal accrual, and that just sort of makes it a little worse. We've invested a lot of time as a consortium developing training for patient navigators. So this is something that, again, is a resource that we have. We don't want for people to think they have to sort of create this from scratch. We've spent a lot of time developing it. We have a patient navigation manual that we've created for EMpaCT, again, to develop some consistency across the sites in terms of the trial that we're currently conducting. We do some, there's didactic content that's provided. We actually have our navigators across the sites participate in some role plays to simulate those patient navigator interactions. There are interviews with clinical investigators. We have discussion panels, and we have small group discussions. One of the important things that we learned from our navigators across the sites is that support, because there aren't a lot of navigators at every site, particularly in the cancer centers. And so the opportunity to have ongoing training as a group is important for them. So we provide that via distance.
Question.
Yeah.
What kind of background do your navigators have? Like, are they previous patients who participated in the trial, or are they more clinicians?
So it's a really, I would say it's probably a little different per site. Most of them just have a lot of community interest in health disparities. I would say there's probably some relationship to cancer in some way. A lot of times it's a family member, a close friend. Our navigator here at Hopkins, who actually just recently left, started becoming interested as, I think her work was in public relations originally. She was interested because her husband needed a bone marrow transplant about a decade ago, and started doing a lot of community activism, realizing that minorities, it's very challenging for minorities in terms of bone marrow transplant because not very many minorities donate. And so she really spent a lot of energy at the grassroots level trying to increase awareness of the importance of increasing registries and participation. I think we just have, it's a really rewarding opportunity, I think, for a lot of individuals. It's that opportunity to give back, and we'll talk about that. That's a theme that echoes sort of across this group, and not just the patients, sort of our populations. It's a good question. But really, all that's required, so for example, for our patient navigator job description, we require a high school education or higher. I would say most have a little college, but again, that background is really varied. It's definitely not in healthcare. So our patient navigation training manual, I'm not going to go into this in a great deal of detail, but just tell you sort of what we cover. Some information about clinical trials. Again, these folks are going to be translating this information to patients, understanding what it is that we're trying to accomplish in patient navigation, what a patient navigation is, and then just some important skills. probably we could all benefit from this in terms of being good communicators, setting boundaries, particularly because they're going to be interacting very closely with patients, hearing a lot about their lives. Again, how we deliver the training content. We do have our manual of operations and procedures, and this is, again, something that is available through EMpaCT. I think there's some discussion about how we're going to make this accessible to folks. Right now, you could request to take a look at it. I think we're talking about whether we can add this to the web portal. And really, as we've looked at the web portal, one of the things that we will be developing is a section for patient navigation, because we do have more patient navigators across the country. So this may be sort of a clearinghouse of information for them in terms of minority issues surrounding trial recruitment and retention. So I told you that we did some interviews, just sort of a little bit a caption of what we heard from some of our representative stakeholders. As I said, there were training needs that were identified. This idea of how we learn to do things through osmosis instead of formal training was identified as a need. It took us to the development of the web portal. We heard something similar from our referring clinicians. Just not really feeling comfortable because they didn't perceive that they had the background to do this kind of work. I think from the PIs, just sort of multi-layered difficulties and maybe barriers to recruiting folks to clinical trials. And again, it's difficult to recruit everyone to clinical trials. I'll talk about the data surrounding that in just a moment. But then it's even more difficult to recruit minority participants to clinical trials. And so just getting to the folks is really challenging. And we did hear certainly some things from the PIs that echo the referring physicians and the cancer center directors as well. And the research staff, again, the folks on the ground, feeling like it's a little fuzzy what they should be doing. Should they be doing anything? What should they be doing? What are the best practices? So currently, as a consortium, I mentioned that we're conducting some trials. We're looking at how can we increase the number of minorities participating in specific trials using patient navigation. And so here at Hopkins, we are the only site who will actually be randomizing patients to patient navigation. The Cancer Center actually is very excited about the use of patient navigation. So as happens to researchers, they really want us to navigate everybody. So we've compromised, and we'll have high-intensity navigation and low-intensity navigation, which will really be a navigator providing some of the basic patient education materials that we have already. And the Cancer Center has invested, along with NIMHD, some funds, so they're providing I think they're providing a navigator for us to conduct the trial, and then based on the data that we have in the next year, we'll look at how that goes forward. So we've heard a little bit from our different stakeholders. I also wanted to just include a statement from one of the patients. Because we have a lot of distrust in our community, it is highly warranted. Consequently, when people approach you with different things, you do not know whether or not it's for real. And then you also do not know, in fact, the impact of the effect it will have on you. I think not only on this issue, but in general, we as patients really focus more, if we focused more on the common good, we would be better off. So this clinical trial is about the common good. It is a good thing. Questions about EMpaCT as a consortium before I move on, and some of the work that we're doing nationally, before I talk a little bit more about some work that we've done here. Yes?
So you said something about how recruiting minorities is more difficult. Is retention of minorities more difficult, or is that
Yes.
about sort of?
No, actually retention is also more challenging. We know that. And I should say, I was reading, you know, I keep sort of scanning the literature, as we all do, hoping that the numbers have improved, you know, but they haven't budged much. In fact, what I read was that actually the trend has decreased over time in terms of overall accrual to trials. This is partly because we have a lot of trials, probably, but for different reasons, actually, in some ways, overall participation to clinical trials has not improved. It's sort of worsened over time. And because minorities represent a smaller percentage of those who do participate, that means that that has actually definitely not improved over time as well. But I think I saw information about minority dropout from clinical trials being about 20%. I want to talk about some of the other numbers again. You add everything up, it doesn't look good. It's a good question, though. I think we tend to focus a lot on recruitment. I think we need to focus a lot more on retention than we do. Okay, so I'm going to talk a little bit about what we're doing here. I'm going to start out with sort of what I was brought on here for EMpaCT to start with, and then they just sort of decided to keep me around. So we've talked about sort of the focus of EMpaCT. Let's kind of take a little bit of a step back in terms of what is it that looks so grim. So first of all, we have, for our racial and ethnic minorities, higher cancer incidence, higher mortality. Nationally, we have about 3 to 5% of adults participating in cancer clinical trials. That's a pretty small percentage. Of those, of the 3 to 5%, 10% of those are racial and ethnic minorities. So again, not very good numbers, and we'd really like to see those move. Locally, from some data that we have from Maryland, led by Bronstein here and Dr. Poe, African American men and women in a random survey of more than 700 outpatient clinics, 700 patients at outpatient clinics, 13 clinics in Maryland were represented. 36 of these were Black, the remainder were white, but of these, African American men and women were surveyed to be only 60% as likely as whites to enroll in trials, and men were the least likely. Again, this is sort of the given. We hear this over and over. Men don't want to participate in trials. Particularly, men won't participate in your focus groups because they definitely don't like to participate in any place where they have to talk. Really, a lot of the research that we've seen so far has been focused on barriers and facilitators to clinical trial accrual. So what is it that people are so concerned about in terms of clinical trials? Can you guess? What is it that people don't like about this?
Experimenting.
So, that comes out. Generally, apparently one of the cited reasons is the idea of randomization. And this is something that we talk about with our community advisory group for our Johns Hopkins Center to Reduce Cancer Disparities that I'm also a faculty member of. Randomization is tricky. I told you we're the only site to be randomizing. We really have to have discussions about this. There's recognition about the scientific importance of this, but there's a lot of insecurity. This is not isolated to minority groups. People don't like the idea of a flip of a coin. We're a nation of choice. We're all about choice, not having decisions imposed on us by random chance. So philosophically, Americans just have an issue with this. Other countries, not so much. In America, we have a lot of issues with this. The idea of sham treatment is really uncomfortable, the placebo. That feels very uncomfortable for folks. One of our investigators with EMpaCT Primo, Laura, and his group at UC Davis actually did a prospective survey and found that of patients and investigators tracking reasons why people chose not to participate in clinical trials. People want to be able to choose. That was the top one. So we talked about this is America. We want to be able to choose our treatment. You can't tell us what to do. Sounds very familiar. Transportation or distance from the treatment center. Insurance non-coverage, when we start looking at minorities who tend to be underinsured, okay, this also becomes an important issue. And then 11% other, meaning they don't want to tell us why they're not participating. They just don't want to. So following in others' footsteps, we decided, well, let's look at what are some of the barriers and facilitators here at Hopkins. We recognize this is Hopkins. We're a little different. We don't say we're like everybody else, every other treatment center. So for our patients here now, or I should say, in 2011 when we were doing this work, what were the barriers and facilitators that patients identified to enrolling in early phase therapeutic clinical trials here in our comprehensive cancer center? We wanted to be able to describe what's this process of decision making like for our minority patients. And we wanted to find out from them what do they need to help them in this process of decision making. So that's what we set out to do. In 2011, we hosted 7 focus groups. We had, and this is probably our strength, we particularly went out to get folks who had decided to participate in trials and those who did not. You can see our inclusion criteria. We wanted folks who had been treated for breast, colon, lung, or prostate cancers within the last 5 years. Obviously, that involved a cancer diagnosis and treatment. They had to have been offered participation in a clinical trial. And we'll talk a little bit about our inclusion criteria too, and how that was challenging for folks. What is a clinical trial? I think I was offered one, but I'm not sure. Our focus again here at Hopkins has really been on our largest minority group, which is African Americans. So they had to self-identify as African American, had to be adults, English speaking, obviously since they're participating in focus groups, and poor functional status was an exclusion. So we had 32 folks who participated. We actually took people who represent minority groups and trained them to be our focus group facilitators. We had research staff there to record field notes. Our groups lasted about 90 minutes. We did provide a small incentive to participants, paid subway fare or parking to assist them with travel. We developed a semi-structured interview guide, and the topics covered everything from their cancer diagnosis experience, because you really can't talk to cancer survivors without getting past that discussion. That's what they're going to start with, so you might as well start there with them. Attitudes or understanding of what cancer clinical trials are, why they chose to participate or not participate, and suggestions on how we might do a better job than we do right now. We did all the things that you should do with focus group discussions and interview data. We recorded these and had them transcribed verbatim. We used a process of content and thematic analysis for our data. We had 4 coders, and our iterator reliability for coding was greater than 0.8. And we actually created a conceptual model, which I'll show you this morning, and this was reviewed by all of the coders and all of the investigative team. So that's kind of what we did. There we go. So you can kind of see we didn't really have a lot of differences, actually. We did have men participating in our groups, which was pretty amazing. We were pleased about that. Males tended to be just a little bit older. They were less likely to report lower incomes. But again, really no statistically significant differences by either participation status or gender. You can see most of our folks, we had that 5-year window post-treatment. Most of them had been treated in the last 2 years. Acceptors were more likely to report lower income. Again, not a statistically significant difference, but we saw that. In terms of comparing our data to what we generally see in the Cancer Center in the same study frame, we only have data on clinical trial acceptors. We don't track the folks who refuse very well. Our study population actually looked a lot like our cancer patient acceptors. Age-wise, our median age was 58. In the Cancer Center, we see 57. Compared to Cancer Center patients, our participants were a little more likely to be female, 57% in our sample, 49% acceptors in the Cancer Center. Again, I think it's because we were asking them to talk in the study. A lot of studies, you don't have to talk so much. So.
How did you recruit these patients?
Yeah.
Is this like a random?
No, we actually had access to the Cancer Center databases. We used a HIPAA waiver to find out some information about the patients. And we also had clinic staff who recommended patients for the study. So we had some help that way. Again, we actually had a fair number of people who were willing to participate. It's just that not all of them had actually been offered a clinical trial when we came down to it. So let's talk a little bit about what we learned to address study aim number 1. So we have some facilitators and some barriers that were presented by patients. Facilitators, it really helps if I have a good rapport with my healthcare provider. And this begins from sort of the referring clinician who sends them to the center. So it's really sort of even before they get here that's important. And then once they get here, what's that experience like? Do they feel comfortable with the doctor, with the nurses? Financially, you know, am I able to take a leave of absence off work? And, you know, financially, how am I doing? This has a lot to do with, you know, how I'm going to feel about being asked to participate in a clinical trial. What do I know about other people like me who have been in clinical trials? Have I heard anything from people who look like me or who might, you know, be perceived to be in my situation? Have I seen anything in the public? Is there any information about what clinical trials are? I think this issue about the personal and moral imperative, we see this for everyone. It's a major motivator, the idea of altruism for participating in clinical trials. I think what we learned in working with our population here is this is enhanced for our population, and we'll talk a little bit about this, but there is this idea that my people, my particular group has been left behind historically. I don't want us to be left behind from, you know, the benefits of scientific advancements, particularly related to cancer, which again, you know, has this, the anti sort of opt-in cancer. I think in African American communities, the idea of cancer is taken very, very seriously. We understand that for science to advance and for us to receive the benefits, there should be some participation. There's actually a fair amount of understanding about that. It is matched to some concerns. This idea of the social network support is really important. I think that is important for everyone related to all aspects of care. Again, we're sort of seeing here that it's very important. And then there was this idea of being very sensitive to context in how we recruit patients. We'll talk a little bit more about that when we talk about our results. So what are some barriers? Don't tell me about clinical trials at the time that you always talk to me about clinical trials. When I just found out that I've been diagnosed with cancer, when I have a lot of decisions to make about treatment, about my life, about my future. So don't tell me about something new at a time when I'm sort of reeling from all of the other information that you gave me that's really important. It's a problem when patients don't have confidence in the medical system. Medical mistrust is cited in the literature as a major reason why minorities do not participate in clinical trials. I will tell you this was not a problem for us. Very few of our patients talked about medical mistrust. What they talked about was a little bit of research mistrust, which is somewhat different. So what we heard over and over is, I trust my providers, I trust the doctors, I like them, we get along well. I trust the nurses, I feel like they're giving me information that's valid. I like the research staff who are talking to me about the trials. Just a little concerned about being in a research study. So again, this is a little different than what we see in the literature at large. In our group, we talked about this at length because we were, everybody, when we were doing the group, said, oh, we really want to find out what you're learning about medical mistrust because we're sure this is an issue. And I had to be honest and say, we're just not seeing it. I think it's because Hopkins is not the easiest place to get access to. And I think if you made it in our doors, you probably look a little bit different. If you chose to come in here, if you were able to make it in, my guess is you look a little bit different maybe than the general population of other folks with cancer diagnoses. Definitely we heard about knowledge and education, not knowing what clinical trials are, to try to actually learn generally about clinical trials before you're presented with one specifically and have to make a decision about whether to participate. This was a significant barrier for patients. And this idea that I think is really coupled with this idea of financial well-being, I don't want to make anything worse, okay? I'm already pretty devastated. I'm already very fearful of the future and the present. I don't want to delay my recovery. I don't want to increase my time off work. I don't want to have more symptoms. We heard actually quite a bit about side effects and symptoms. And again, coupled with this idea of financial well-being, what is it going to cost me to participate in the trial? And cost, it can be time off work. Again, it could be other sort of life issues that are complicated by participating in a trial, child care, multiple issues that can engender cost. More visits here. So we are going to skip to specific aim number 3 because they had some really salient recommendations for how we could do a better job. And you can really see how these are matched to the barriers and the facilitators that our patients identified. So increase public awareness, have education campaigns about cancer trials so that you're not hearing about clinical trials and cancer-specific trials after you've walked in the door of the cancer center. You need to find out about that before you get here. Increase opportunities to expose folks to narratives and experiences of people who have been in trials that we're talking to them about, of people who look like them and who they perceive contextually may have a similar experience. Make sure that there's insurance coverage for clinical trials. Be aware when we approach patients about participating in clinical trials where they are in terms of their diagnosis and treatment trajectory, and being sensitive to that, giving them some time. Janice and Mann, whose theory of conflict decision making I've used for some other studies, say that time is the really critical factor in decision making, in making good decisions. And time is something that cancer patients don't always have a lot of in terms of decisions related to treatment, particularly depending on the type of cancer they have. We sometimes are really pressing them to make decisions pretty quickly. and making sure that they said, have people talk to us that we trust. And again, it's not because they don't like the research staff that we have on board. We only heard good things about our research staff. But I thought this was the amount of savvy that our patients have, which sort of tells me that maybe they're not representative of every patient out there. And we're talking about patients at different income levels. You saw this is not everybody was highly educated or very well off, but patients really said, you know what, we like the folks that you have here. They're good people. We think they're trustworthy. But when it's the investigator talking to you about his or her trial, when it's the research staff talking to you about their trial, isn't there a little self-interest there? And even if they're trustworthy, still they can't help but really, they do have some interest in getting us in the trial. Well, that's true. So they said, have somebody who doesn't have anything to do with the trial talk to us about your studies. It's like, well, what a good idea. So our results, thematically, we ended up with 3 themes. That information gathering and processing influences ultimate decision making. That interpersonal influences were also very important in this process of clinical trial decision making. And that decision balance was the desired outcome. Questions about how we did the groups before we sort of launch into what we heard?
Did you also do a focus group on majority patients? I mean, you showed us minority, but we need to see how that compares.
We didn't, and honestly, it's because that's not what the funding that we had was for. But
I mean, those all seem reasons for any clinical trial for not specifically minority patients.
that's exactly what we've heard when we've presented to other stakeholder groups. So again, I think there's probably one important area of difference that we'll talk about, but again, that's exactly what we've heard. And I don't disagree. I think this makes good sense. Again, we had a small amount of pilot funding, actually got a lot of work done with it, but that isn't actually what we were funded to do, so we weren't actually able to do those particular focus groups. However, it's a good project for the Cancer Center, I think, and we do have survivorship and patient advisory groups for the Cancer Center since the focus groups that may be helping to advise on some of these issues. Yes?
Related to that, I was wondering whether in these focus group discussions with the African American community at your site or maybe outside, how much did the historical examples or the bad examples of Tuskegee or the Henrietta Lacks story, how much did those instances come up?
We'll talk about that. Actually, it is one of our findings. So if you can hold that thought, and then if I don't hit it correctly, let me know. So let me tell you what something that we heard from one of our decliners. My contention was, I'm not ready to experiment. I want to get the cancer out of me and go forward. Again, I think we hear this from a lot of folks. I don't think this is not specific to race or ethnicity. I dismissed the clinical trial invitation and moved on. In retrospect, probably should have examined it further. But as others in this group have expressed, your mind is going through so many different changes, so therefore, an extra decision you've got to make about something that, yes, perhaps could be beneficial, but is not really the direct course to being well. I think you can probably guess the decision that participant made. No. But we did hear some regret about those decisions made, and that, I think, is the intervention point that we have, and where we think that we can really begin to make some differences, perhaps, in moving these numbers that we've been seeing. I'm going back and forth too much. I've been talking too long, it got stuck. Okay, there we go. right, so our first theme about information gathering and processing. We had the issue about how clinical trial information is communicated and the information that's available on that. Again, this idea about economic feasibility and side effects of treatment. And then what we've called the health disparities dilemma. One of the things that we heard was that patients heard a lot about the side effects that they might receive if they were on trial treatment. But the standard of care trial therapy offerings were pretty played down. And we're talking to people 1 to 2 years primarily after treatment. They said, geez, if I'd known I was going to be that sick, I would have just participated in the trial. But it really sounded like, oh yeah, your regular treatment's going to go fine. If you're on the trial, well, let's go through all these risks and side effects. So they said, those were the same side effects I experienced with the treatment that I chose. I think this tells us something about just clinical practices and how we're communicating about therapy, that I think in the clinic where I've been, we may underplay the actual side effects that patients are going to receive on therapy, any therapy. But when we talk about trial treatment, that's sort of another layer of consent, and we really kind of go over those exhaustively and in a lot more clarity, so patients are, pretty well aware of what they might experience on trial, a lot less aware of what they're going to experience with standard of care therapy. I think we've talked about the clinical trial communication. Again, when we talk about the health disparities dilemma, we have historically this idea really raised by men in our study. So women didn't talk about it. Egregious historical misconduct in research, and how minorities have been treated in past research. So we did hear that. We heard about Tuskegee. It's really interesting. We didn't hear about Henrietta Lacks. We heard a little bit about death carriages here in Baltimore. But that was really by people who are like, oh, you're going to hear these things, but they're not true. People will tell you, oh, you can't go to Hopkins because I've heard really strange things about what they do there and the experiments if you end up going there. That was really related by people who said, oh, people just don't know what they're talking about. You want to come here if you want to get good treatment, things like that. But men did talk about, hey, as a black man, I can't forget about Tuskegee and what happened there. But as a black man with children who lives in a community that I care about, I also really want to think about the fact that we don't want to, again, this idea of not being left behind. This created a dilemma that I don't think everybody has to worry so much about, because we know that the altruism benefit of participating in research is an important one. And again, it's a major motivator for people to participate in research. But altruism here has, again, sort of a more enhanced context. There's more writing on this idea of being altruistic, representing your minority group in a positive way, but also greater concern. So there's a lot of tension that I don't know that we always recognize very well. We have to wrap. Okay. This idea about interpersonal influences, one of the things that we have not, I think, focused on well, but that was really evident in our discussion was that there are decision partners who may actually be making the primary decisions about clinical trials. We had a patient tell us the overriding influence for his participation didn't come from his medical practitioner. It came from my wife, who was saying no, no, no. We had patients who prayed about their participation in clinical trials and, again, talked to their family and felt like they could go forward and had some confidence about that. So we talked about this central issue about decision balance. What's sort of riding on the balance spectrum? It's this idea of being satisfied with the decision that you made to participate in the clinical trial, or experiencing regret related to not participating or to participating, so whichever decision you made. I will say that we heard more regret from people who actually declined participation in clinical trials. Again, I think that's the opportunity that we may have. And what they said is, I think I would have liked to have been better informed. I might have said, dang, if I'm going to be that sick, maybe I should have just done the trial. Maybe I would have been able to help the next person, or even myself. This is the model that we talked about. I've included some of the barriers to research participation for minorities. That was done by John Ford when he was here, just sort of as that contextual piece. We see the decision processing in the middle, that idea that we can have balance or imbalance, and that all of this is really tipped by information, how we provide that to patients, how we can make clinical trial participation more feasible for them, the backdrop that they have in terms of health disparities, and for them, cancer disparities as well, which they are aware of, and the interpersonal influences that can also help them. The issue about decision partners that's important is that they can be in agreement or disagreement with their decision partner. When you're diagnosed with cancer, the likelihood is that you're going to defer to your decision partner, because patients with cancer already perceive that the cancer is a terrific burden for the people around them. They don't want to overburden these individuals anymore. We had patients say that they were really, these are not people who are like, I really want to participate in the trial. These are the people who are like, I could participate in the trial, that would be okay, but, you know, I need to think about it. The decision partners who are actually not heavily involved or engaged in the cancer center, in our clinical trial discussions many times, that information is related to them, and you can imagine what their response is. I don't want you to be a guinea pig. I don't want you to take on additional burden when you've already been diagnosed with cancer. We're looking at your cancer. We're looking at the treatment and the side effects. No, I don't want you to take any more. The patient says, I don't want to increase the burden of this anymore. So everybody's protecting each other in this case. And what happens is the patient says, you know, I don't think I can participate in the clinical trial. And that's fine. If, again, that balance is in place and they have resulting satisfaction with that decision. But what we heard many times is when there wasn't concordance, that, you know, looking back, I really wish I had made a different decision. And that, I think, is what we can change. Decision partners, by the way, when we talk to them, because we did a follow-up study with them, they don't really have any idea how important their role is. And even the ones who actually ultimately made the decision didn't realize that they made the decision. The decision partners would say, oh, it's the patient's decision. But their input and their perspective is heavily weighed by the patients in this process. When we work with minority groups and with minority population, this idea of community and support networks is very important, and it's broad, and it doesn't always look exactly like everybody else's support network in terms of the role of spirituality, the role of the church is really intensified for this group. So at the end of the day, what we see is that for our patients, for our minority patients and their families, the decision to participate in the cancer clinical trial is a very complicated one, and it's a balancing act for them. And I think we could do a much better job of helping them create that balance, of helping them with the different factors that feed into that balance or imbalance. There's a lot of weighing of the current needs versus the implications of participating in research. And there, again, is this important deliberation for patients about the issues related to science and good science, and then their bioethics concerns. Decision-making outcomes we know can have important health and health disparities implications. And I think what we heard from one patient is when they have trials like that, these should be offered before you go through your other stuff. That would be your opportunity to make a difference. But no, they wait until you go through all this stuff and then they offer you a trial. I think that's our opportunity to make a difference, to partner with patients and with their decision partners, with all the stakeholders who are involved in these decisions and with the actual trials. And on behalf of the EMpaCT Consortium, thanks for your time this morning.
Well, thanks. That was wonderful, and it gives us a lot to think about. I would ask maybe if you come up here if you have any questions. But thank you very much, Jennifer. I've got some questions. Oh, yeah. And I want to tell students in the audience that I got a lot of trial data from asthma that you could look at what influences patient dropout, you know, demographic and asthma severity, like 10 trials you could put together. It'd be a good little project.